Good afternoon and welcome to our webinar, Frankly Speaking About Advanced Breast Cancer, Improving Patient-Provider Communication and Shared Decision-Making, hosted by the Cancer Support Community. I'm Ivy Ahmed, Vice President of Education and Outreach at the Cancer Support Community. Before we get started, I'd like to go over a few housekeeping items. As mentioned, today's program is being recorded and will be made available on the Cancer Support Community website at www.cancersupportcommunity.org/webinars. The format of today's call will be as follows. Our presenters will be featured first, and then we will begin the question and answer portion of the presentation. For those of you participating over the computer, to ask a question, please type it in the question box you see in the webinar user screen. You may submit a question through the box at any time during the event. Additional instructions on how to ask a question over the phone will be provided before the Q&A portion begins. We will try to answer as many questions as possible. For those of you online, before you close out of the webinar, you'll be directed to the post-event survey. Please complete this survey as your input is invaluable to us, and the survey should take only a few moments. For those of you new to the Cancer Support Community, we'd like to provide you with some background. In July 2009, the wellness community and Gilda's Club Worldwide joined forces to become the Cancer Support Community. By helping to complete the Cancer Care Plan, CSC optimizes patient care by providing essential but often overlooked services, including support groups, counseling, education, and healthy lifestyle programs. Today, CSC provides the highest quality emotional and social support through a network of more than 50 local affiliates, 100 satellite locations, and online. CSC also offers the Frankly Speaking About Cancer Advanced Breast Cancer book and CD-ROM. These programs include information about advanced breast cancer, treatment options, managing side effects, and tips for interacting with your healthcare team. For this book and other program offerings, please visit our website at cancersupportcommunity.org or feel free to call our toll-free number at 888-793-9355. It is now my great pleasure to introduce our featured speakers, Dr. Lydia Shapira, Erica Fisher, and Margaret Stauffer. Dr. Lydia Shapira is a medical oncologist at the Gillette Center for Breast Oncology at the Massachusetts General Hospital and an assistant professor of medicine at Harvard Medical School. She trained at the Beth Israel Hospital and the Brigham and Women's Hospital, both in Boston, after graduating from Dartmouth Medical School. Her interests include psychosocial care of cancer patients, doctor-patient communication, and improving access to clinical trials for underserved patients. Erica Fisher is a breast cancer medicine clinical nurse specialist at Memorial Sloan Kettering Cancer Center. She's also a registered nurse for chemotherapy infusion at Overlook Hospital in Summit, New Jersey. Erica received her master's in nursing from Drexel University. And Margaret Stauffer is the Vice President and Program Director at Cancer Support Community's San Francisco Bay Area affiliate. In her current role, she develops new program components, supervises the clinical team, and ensures wide accessibility of programs to people affected by cancer. She is a licensed marriage and family therapist. I will now turn the program over to Dr. Shapira.
Good afternoon. It's really a great pleasure to be with all of you, and in the next 10-15 minutes or so, we'll talk a little bit about treatment options and considerations for patients. Shared decision-making begins with informed patients. So in our roles as healthcare professionals and advocates, it's really important to focus on providing accurate information and helping patients come to meetings prepared and sort of knowing what to ask and to be oriented to the topic. I have no disclosures for this presentation, so I'd like to start by just asking you please to vote or give us your opinion on this question. How often do you care for people with advanced breast cancer? We'll start with some definitions. Cancer that is considered advanced is cancer that has spread from the ducts or lobules of the breast to a different part of the body, and it is also known as metastatic breast cancer, and in the staging it is considered stage 4. Bottom line is stage 4 or metastatic breast cancer is very treatable, but it is not curable. When we think about the treatment goals for advanced breast cancer, they are quite simple and straightforward. They are to prolong survival, to delay disease progression, to manage the burden of symptoms, to maintain function, and optimize quality of life. Clearly, some of these things are very precise, such as prolonging survival, but others really depend on a patient's experience and her values, such as optimizing quality of life, because for some patients, for instance, maintaining perfectly normal routines is far more important, perhaps, than prolonging survival by maybe a short number of weeks or months, whereas for others, just prolonging survival is really, really the most important thing and will often dominate their decision-making. When we think about helping women who are facing these important considerations and thinking about, again, the goals, we also need, of course, to understand who we're talking to. We need to consider and understand and connect to our patients and consider their individual goals, their preferences, their backgrounds, their worldviews. We need to help them think through options. We need to help them think through what they could possibly benefit from and also what they may be sacrificing. So you can think of this in many different ways. You can think of them this as facilitating somebody's way of thinking through options, exploring trade-offs, articulating their own ideas and preferences, prioritizing what becomes most important, and be very mindful because these goals may change over time for several reasons. One is that the nature of the disease itself may change. The nature of the symptoms they're experiencing may change. If, for example, the clinical picture is dominated by pain from bone metastases, it may be very different than somebody who has perhaps a lot of disease in lymph nodes but has fewer symptoms. There may be a shifting of new priorities because of life events, because of experiences that matter or are the most meaningful to our patients. For instance, many of our patients will want a treatment holiday around the time of a family vacation, or will want to have their hair for a family wedding, or want to be present at a very important graduation ceremony. So we need to be very mindful that disease changes over time, goals and priorities may shift over time as well. And this becomes important too, not only in starting and choosing a treatment, but sometimes deciding when to end. Either end permanently, as in a very palliative situation where we focus on ministering to comfort and not so much thinking about treatments that need to conform to certain schedules and may cause real lifestyle interruptions. And it's also really important as we're helping these women come prepared to their consultations to clarify any misconceptions. And one of the most typical ones is that focusing on palliation may hasten death, and that is absolutely not true. So let me turn to a brief overview of treatment options. Even in the metastatic setting, sometimes it's important to give local treatment. For example, you may need surgery or radiation, and these are given with palliative intent. I saw a woman this morning, for instance, who has a bulky recurrence in her pelvis, and she's having vaginal bleeding and a lot of pain. And in that case, a palliative surgical debulking is perhaps the best and kindest way to get her to feel better and have a better quality of life in this situation. Systemic treatment is based on the biology and the symptoms, and so it may involve a treatment that is directed at one site, such as, for instance, radiation to painful meds accompanied by some form of systemic therapy with hormonal therapy if a tumor is sensitive. It may be chemotherapy for tumors that are hormonally sensitive or not. It may be targeted therapy, such as the monoclonal antibodies we all love and use often, such as trastuzumab that you may know as Herceptin, or it may involve investigational agents, and typically those are available through clinical trials. More and more in the treatment of advanced or metastatic breast cancer, we are urging patients to really think about these targeted and or investigational agents because there's been a real surge in the number of compounds that are available, and they are really quite effective. So even patients who are participating in trials where the expectation of personal benefit is uncertain are now more and more increasingly deriving benefit, and these treatments are becoming more tolerable. They certainly have fewer collateral damage than chemotherapy. So what do we want to discuss with our patients about chemotherapy? Well, we need to inform them. We need to make sure they understand and that our thinking is transparent. So I often will, create some doodles or show patients how I got to recommend the treatment that I recommended, perhaps because it's a hormonal treatment based on hormonal sensitivity, or chemotherapy because I think it's going to produce the quickest response and I want my patients to feel better. We need to explain the difference between using one drug at a time or more than one drug. Typically in metastatic breast cancer, many of us prefer to use one chemotherapeutic agent at a time, and we call that sequential use of chemotherapy. But if you need to get a very quick response because a patient is in a visceral crisis or hurting very badly, sometimes we use more than one drug. You use more drugs, you have a better response, but also more toxicity. We need to talk about frequency of treatment. Options for oral agents. Capecitabine, known as Xeloda, is a very effective chemotherapy drug for breast cancer. It's portable, so it allows patients to continue to work full-time perhaps and have fewer visits to the clinic or the doctor's office or the hospital. And many of my patients choose that treatment because of that. We need to identify other health problems that may get in the way of treatment, that may make it less safe or may predispose them to develop certain serious and disturbing side effects. We need to talk about cost. Some of the newer drugs are prohibitively expensive, and if patients have very high co-payments, even though they're not paying for the entire treatment, they may need to make, again, some decisions based on what they'll have to sacrifice in order to get this treatment. And of course, it goes without saying, but perhaps I should repeat here that we need to be very clear about what the side effects are and provide a clear path to managing those. When we're thinking about hormonal treatment for breast cancer, we need to consider where a woman is in her life cycle, whether or not she's menopausal. We need to think about whether or not she may even derive a benefit, and that's based on the hormone receptor analysis of either the original tumor or the biopsy that was taken at the time that the woman was diagnosed with metastatic disease. More and more, increasingly, we're now biopsying metastatic sites, and in about a third of the cases, there's a discordance between the receptors we find at the time of metastases and the original ones. And all of this needs to be explained so that somebody can truly give informed consent or participate in making a decision. Of course, we also need to talk about whatever prior hormonal treatments our patients have had and the side effects. We all know that causing young women to enter menopause is often associated with uncomfortable hot flashes. Drugs like tamoxifen cause leg cramps and pelvic distension and a vaginal discharge. And the drugs that we use for postmenopausal women, the aromatase inhibitors, often cause stiffness in the joints. And if women already have a little touch of arthritis, it may be hard to get up from a chair or hard to get up in the morning, and they may be shuffling for the beginning of the day. But you know what? There are ways to overcome those things. And the vast majority of women, if they understand and they are duly warned of these side effects, and they don't think of these side effects as mysterious, but perhaps they understand the physiology and how they happen, and they've been given some suggestions for how to deal with them and a number to call and some professional to discuss this with, it may make all the difference between making the treatment bearable and making the treatment frightening and unbearable. Other important considerations are to know the HER2 status. HER2 is an oncogene, and about 1 in 4 or 1 in 5 women with breast cancer have HER2-driven breast cancers that we call HER2 positive or HER2 enriched, and other available targeted therapies. We need to discuss the standard treatment first when we talk to a patient. We need to tell them what the benefits and the risks are. We need to tell them why these are standard treatments, how they became standard treatments, and the likelihood that they would work for that individual person. So that's what I think of often when we talk about personalized medicine. It's based on who the individual is and what the characteristics of the tumor are and what kind of resources and treatments are available. We then need to talk also about innovative treatments in this setting. Since there are no curative treatments, these are wonderful opportunities for patients who wish to participate in clinical trials to know more about this and know if that's how they wish to live out their illness. Many patients are very enthusiastic and feel very strongly about and very positively about participating in research that will open the way towards newer treatments in the future. And of course, they hope that in participating, they will also derive a personal benefit. Now, that's kind of tricky, and that needs to be explored very sensitively as well, because many of these clinical trials, they may be very exciting, but often when a patient enrolls, she has no guarantee that she will, A, receive the drug, because many of them also involve use of placebos, or that it will actually improve her particular outcome. So thinking about participation in clinical trials, I think, is crucial. And starting to talk to women who have advanced disease from the beginning about this, it may not be the greatest option for them at that moment, but perhaps later on, if they are already ready and already they understand how the machinery so to speak, of clinical trials work, they may be ready and eager to participate. So when we consider choosing a treatment, we need to think about how quickly our treatment needs to act. Sometimes it's important to find something that will likely work and work quickly, usually to relieve pain or to relieve a very bothersome symptom. And that clearly is often dictated by where the disease is located and also, of course, by the general physical state, age, health status, and goals of the patient, and, as we said earlier, about the disease biology. So that's what I think of and we think of as healthcare professionals, but what do our patients think about when they choose a treatment? Well, from a poll that was taken by the cancer support community recently, it's important to take home the following message, that patients want to live longer, so they're worried about the effect of treatment on survival, and they want to live well, so they're worried about and thinking about the impact on the quality of life. But look at this slide. The third and important runner-up is the confidence in the doctor and medical team. And that's where we can all come in when we help women sort of get to the point where they really feel that they are known, where they feel they have a fluid relationship with their healthcare team, and that they come into meetings feeling that they really have some good questions and they're ready to hear some good answers. A lot is riding on good patient-provider communication, and it is really essential. It helps build trust. It helps patients feel connected. It builds bonds of affection, of trust. It makes patients feel that, that their healthcare professionals are to be trusted. It engages them, activates them in participating in their health, in making good decisions. It allows them to stick to a treatment plan because they feel they own it. It helps elicit their concerns, calm their fears, know their worries, understand them as people, as individuals, instead of thinking of them as a disease, and it really does establish a solid partnership. So again, while most patients feel, and we know from research that good communication is essential, very few patients really feel completely satisfied. If you look at this slide, which comes again from the data gathered by the cancer support community through a voluntary survey of patients with advanced cancer, we see here something that makes me very sad, which is that, in fact, 40% or so of patients feel that they infrequently discuss things or never discuss things which are really worrisome to them. So there's a lot of room here for improvement. So the challenges to good communication, what are they? Well, some of them are pretty obvious. We run out of time. We are pressured. We are stressed. Patients often are anxious, overwhelmed. They may be ashamed of really stating what they're afraid of. They may not even know how to articulate it. They may save the biggest concern until last, and then we've run out of time. we recognize that this is an emotionally distressing time. And when people are also anxious and perhaps the doctor or the nurse practitioner is busy or isn't particularly warm or doesn't not particularly skilled in eliciting the concerns, things can really go wrong. Another important thing to consider is that not all of our patients really have a good working understanding of disease or of science, and that just handing out perhaps good printed materials may not really be very helpful if they don't have a good reading level or they just don't know how to navigate through these complex tools. So we need to learn to avoid using jargon, to make our explanations ridiculously simple, perhaps to have some repetitive conversations, and then learn some techniques from educators who really know how to work with populations that perhaps have lower literacy, and perhaps also, depending on where you work, you also know that sometimes low English proficiency gets in the way to having meaningful conversations. So it's beyond the scope of our presentation, but I think thinking about involving professional interpreters, thinking about what a patient's literacy level is, and making really sure that she really understands her options, her disease, and participates as much as she wants to. So here's our wish list to improve communications. We would love patients to come prepared with key questions and be ready to really clarify their concern. We would love cancer teams to assess the impact of cancer on all of the treatment, on all of life's major domains, so the impact of both illness and treatment on all major life domains. We'd love to assemble a multidisciplinary team, and perhaps the composition of the multidisciplinary team will depend on what the person's needs are, and that's truly personalizing it. We think that clear lines of communication are absolutely indispensable, and we need to make sure the patient knows who to call, how to call them, and how to get in touch with any of us if they have either worries or symptoms. And we all need to agree on what the next steps are. At one meeting, we can really not accomplish everything. So we need to be sure that we have a follow-up plan, we have a clear strategy, we have everything in place, and that the patient feels supported. With all of that, and having created this introduction in a way to the importance of having a multidisciplinary team that involves people with different orientations, we need social workers, we need advocates, we need skilled nurses, we need physical therapists. I would love to conclude my presentation and turn it over to my colleague Erica Fisher from Memorial Sloan Kettering Cancer Center. Thank you very much.
Thank you so much, Dr. Shapira. So I'm really glad to be here today to talk a little bit about what specifically is on the minds of many of the women that we care for with advanced breast cancer. And kind of looking at the results of the question Dr. Shapira put to the group, it looks like about 70% of you are caring for this patient population on a regular basis. And then with the majority kind of seeing them in and out, and then a small group of you not seeing them really so often. So we kind of come from a variety of backgrounds in our exposure to these patients. And sometimes it doesn't really matter if you're caring for them on a regular basis. To know these things can help care for the neighbor or the friend or the other parent that you run into who is recently diagnosed. You don't necessarily have to be their caregiver to use these to really benefit a patient or a loved one or someone that you're interacting with. So I as well do not have any disclosures to discuss here. So with that, we'll move right along. And some of the key assumptions that we make with this patient population are not always the true ones. And so the true assumptions we need to know is that this population is unique. It's not like years ago where a diagnosis of metastatic cancer meant that there were a few months on the horizon. These are women who are living for years and years, and as a result are carrying on their normal day-to-day activities as well as being a cancer patient. They're still executives and teachers and moms as well as a cancer patient. And so empowering them to really engage from the beginning in being educated about their diagnosis and their treatment plan and their options is important to making sure that the cancer patient part of them isn't the majority of their identity and really just a subset of who they are in the world before their diagnosis started. And so from day one, encouraging them that they're a part of this team and asking questions and really taking into consideration their preferences and goals. If a patient really has something they want to accomplish, they want to go to that family wedding and they want to be able to have their hair styled or not have everyone looking at them, really taking those things into consideration is our job as clinicians, because quality of life really is the number one thing that we're focusing on with this population. So understanding that this is really going to be a chronic, lifelong diagnosis that they're dealing with, as opposed to something short and curative like we deal with adjuvant patients. So when we looked at a group of women with advanced breast cancer, there were a variety of things that they said they experienced. And dealing with this population on a day-to-day basis, I think this is really a great example of what the bigger population is feeling. They are uncertain and feeling vulnerable. They're never sure what the next day or week is going to bring in terms of how they're going to feel or what's going to happen next. And there's a lack of control. So they went from really kind of making all the decisions in their life in most cases to now being told when they need to take off of work for a doctor's appointment and when they need to go for imaging. They can't necessarily control how their body feels from a day-to-day basis. And so kind of taking a lot of the control out of their hands with this diagnosis can contribute to those feelings of uncertainty and vulnerability. A lot of times their normal life things are disrupted because of chemotherapy schedules or doctor's appointments. And then there is this feeling of hope but not wanting to have too much hope. So women especially who have rarer cancers and not as many treatment options are always hoping for something newer to be FDA approved or available to them, new clinical trials, and really kind of aggressive treatments, because despite knowing that this is going to be a chronic lifelong disease that they now need to always have some type of management for, there is still always that hope for a cure. And so when we look at the resource, it shows that this patient population specifically, there's a big gap in the psychological and the psychosocial support that these patients really receive compared with those that have a curative diagnosis and wind up in remission. And so that's where the onus really comes on us. And so when we look at the things that these patients are experiencing physically and emotionally, they may have hair loss, they may not. They may have nausea and vomiting and appetite changes, and they may not. In breast cancer, we see that this patient population generally does not lose a lot of weight or get skinnier, but a lot of these women gain weight from the treatments. And so there is a depth of body self-image issue that comes into this as well. They can become neutropenic or more susceptible to infection. There's significant fatigue that can come with many of these treatments, and so they may not have the energy to run after the children or to have the number of hours in their workday that they did before. There are sexual side effects, vaginal dryness, decreased libido that comes along with many of the treatments for breast cancer, as well as neuropathy, and then cognitive changes, emotional changes, swelling, shortness of breath. The list can go on. And there are patients that will never have any of these, and there are patients that will have all of these. So really taking into consideration what are the things that are the most bothersome for the individual that you're dealing with, and what can we do to make it better. So when they looked at a survey of these women and they wanted to know what were the things that were seen most frequently over the last 3 months, it was the fatigue. And some of that is physical fatigue, and some of that is psychosocial, emotional, and psychological fatigue from the diagnosis, from the treatments, from everything that goes along with that. We see many of the patients had pain, some difficulty concentrating. Chemo brain is one of the terms that I get from a lot of the patients. And then anxiety over diagnosis, over what's coming down the line, over the future. And then a lot of those other things that we discussed. You can see it's a big subset of patients that have multiple. So what kind of impact does that have? Well, just off the bat, I think we all can tell how we feel when we have a cold or the flu, and that's a short-term feeling of unrest, both psychologically and physically. And so when we take that and we stretch that out over months or years, we can see that there is a lot of lost income from work, being out of work for physician's visits because of fatigue and not being able to perform the job the way that they had done before. A lot of sleep disturbances, being able to focus. Some of the patients find that they really lose a presence in their family's lives. They're not feeling well enough to be present. And so there are a lot of things that as caregivers we can do to encourage them to re-engage in these things. So if they're not feeling well enough to go to the school play or to the dance recital, making sure somebody videotapes it, and then making a family event of watching it all together so that the patient can still be involved and feel present and not isolated from the family. Being intimate with their partners, not only because of the self-image issues that come along with the diagnosis after surgery and scars, and also but because of the sexual side effects. And so a lot of times we need to dig into areas of conversation with these patients that we may not feel comfortable ourselves delving into, but ignoring it is certainly not helping them. And so kind of reaching a level of comfort with oneself, being able to discuss sexual side effects and issues really is important so that you can then extend that level of care to your patient. And then exercise and being physically active. A lot of research shows that women have less fatigue and tolerate treatments better if they can stay physically active. And so encouraging them to do that and get involved in different exercise programs with other cancer patients who are experiencing the same limitations physically and emotionally can not only provide them with the level of support psychologically, but encourage them to continue those physical endeavors. And so I have a question for the group. Do you initiate discussions about psychosocial issues with patients with metastatic breast cancer? So we're going to send that out to you, and if you would answer, we'll touch back about those results in a few minutes. And why that becomes important is because when we ask patients, we know that about 82% of them want to be a partner in this. They want you to ask them these questions and talk to them. They want to be part of the planning and know what's going on. We all have experience those patients who want everyone to deal with the issues except them, and so that's about 10%. They really want the doctor, the healthcare team to captain the ship. And then there is a equally small group of patients who want to captain the ship themselves and tell us how things are going to go. But for the most part, the patients you're going to encounter really want to work with you on this. And so delving into that with them and engaging them is really high on the priority list of being a caregiver for this patient population. So when we talk about how to engage them and why we're engaging them, there's a lot of different ways to do it. But really just saying often to the patient, how can we make these decisions together? What is important to you about this? How do you feel about going with this treatment option? And sometimes it's as simple as saying, okay, there's been some progression and we need to change treatments. Here are a few options that are on the table, and letting the patient work with you to decide instead of only going in the room with one option. It helps patients to feel more in control and empowered, and the more that they feel you're considering them, the more comfortable they're going to be sharing with you their concerns, and how that's going to impact their compliance with treatments is important as well. It also increases the likelihood that these treatments are going to match what the patient needs for the time. Patient just may not be ready to come in every week for IV chemotherapy. And so having that discussion and starting with an oral agent like Dr. Shapira had discussed really can be something that is an option, and we won't know if we don't discuss it with them. It also makes the diagnosis seem a little less scary for them if we're really informing them and making sure throughout the process that they understand where the direction of things is going. And just overall, we see patients have better satisfaction and a better buy-in into the treatment plan when we're involving them. And from all of this, there's just better communication across the lines of everything. So what is our role in kind of moving forward with this? there's 5 things that I challenge all of my colleagues to do when they're caring for this population. And the first is to carve out some time for that patient. Whether it's in person, making sure that you have some time to sit with them, or if you're crazy in the office and you don't get to share that time with them, following up by phone. Never feeling rushed, making sure that they always have the opportunity to express it. And it can be something as simple as on their way out the door saying, if anything comes up that you didn't talk about today or that you forgot to bring up today, please call me. Because sometimes patients can sense our urgency or our busyness or the craziness of our day. And making sure to just remind them that you're there at any point to touch base about something can be enough. Encourage them to ask questions, and I can't even stress this enough, whether it's on the phone, whether it's in person, whether it's in the hallway, or you're passing them in the waiting room. Always saying, is there anything I can help you with? Do you have anything that you want to ask today? And then taking the patient's concerns into consideration with treatment planning. So if they really are not ready to lose their hair, advocating for them for an option that won't have hair loss may be something in the beginning that's important, especially when you're at the transitional period where a patient is moving from, say, an oral therapy to an IV therapy. That's a psychological change. It's almost like being re-diagnosed again for some patients when they've had all this time on an oral agent. To now have to come and sit in the chair and get an IV is a different feeling. And so if we can take into consideration and make that transition a little bit easier for them, then it can ease the process for them in their coping. And then respect the patient's non-cancer life. So understanding that if a patient really can't come and see you on Thursdays because Thursday is when they go to Mommy and Me class, or that's when they go and read to the kindergarten class, making every opportunity that you can to meet those needs of the patient and changing the treatment day or working around their schedule, because we really don't know how long they're well enough to do these things. And so respecting them shows not only that you respect the patient as a person, but that they're not just their diagnosis. Also, providing continuous reassurance. Even when they're not having symptom problems or side effects of treatment, reassuring them that you're there for them and that anything that comes up you're on their team for is a way of just knowing that you have that different relationship with that patient. And so what really is the ideal team to accomplish all of these things? Because it's a lot to put on one caregiver or 2 caregivers. And so we really need to create a more complex team that can meet the variety of the needs of this patient population. And it's a team that instills that trust with the patient, makes them feel respected, is non-judgmental. It asks about the physical and the psychosocial effects of the disease and the treatment, and also considers their personal preferences. And so this is what I really think that the ideal team looks like. And it's kind of a set of cogwheels of social workers, techs, a pain management team, nurses, dietary, nutrition, physical and occupational therapists, the chemotherapy infusion nurses, phlebotomists, radiation oncologists, medical oncologists, and surgeons. And by all of these team members working together, we keep the patient turning. And so from every person that lays their hands on that patient, if we work together, from the person that draws their blood to the person who is going to recommend a supplement or some diet or some tricks for eating, the tech that sees them for their scans every few months. Keeping those lines of communication open between all of us enables a smoother transition for that patient. It keeps the wheels oiled, really. And so what can we encourage patients to do so that it keeps the team moving as well? We want to make sure that they're upfront about how much information they want. Some patients want a lot of information, and they will go and they'll do research and bring you articles before you've even seen them. And some, they don't want to hear anything. They would rather just be directed in what path to go, and they don't want to be part of the decision making. So making sure that you ask the patient and tell them, tell me how much you want to know, so that you can meet their needs. Ask them to bring a list of questions to their appointments, because a lot of times they get so overwhelmed by finally having that office visit that they can forget the things that they wanted to discuss. Having a family member coming with them. Our office can promote a lot of internal noise, And so a patient may not hear everything that we're sharing during the visit. And so having another set of ears to be there can help them when they go home reaffirm what they've heard. Ask them to be open, share their fears and their concerns, talk about the things that are going on in their lives. A lot of times we find patients don't want to share the little things because they're really more concerned about continuing to get the treatment to keep the cancer at bay. And so they ignore the side effects, or they don't tell you about them because they're afraid you'll reduce the dose of the chemotherapy or you'll stop the treatment and it won't work as well. Have them take notes and write everything down. Encourage them to take copies of the test results if it's something that they're comfortable doing. A lot of patients want to see them. They want to be able to see it in black and white and know, because it reaffirms that trust that what you're telling them is real. And so what are some things that we can ask patients to keep that dialogue flowing? How they're feeling overall. What's worrying them the most? So when we go in and we talk about how a treatment cycle went, what was the worst part of it? What was the best part of it? Who are they able to talk to when they're at home? What kind of support system they have? Do they have enough help at home? And are they struggling to care for themselves? Have the symptoms changed since their last visit? Are they better? Are they worse? Is there no change? Is there something new that's arose? And then how is the cancer or the related treatments affecting their lives? Are they able to still go to work regularly? If they swam every day, can they continue to swim every day? If they were playing the violin, can they still play as many hours, or is the neuropathy becoming problematic? And so prompting these questions to things that they may not bring up can really derive a lot of information. You have to be a little bit like a news reporter and a detective all in one, sometimes extracting the information from this group. We could ask them what are some things that they do to manage side effects. We want to make sure that they're not managing their side effects in a homeopathic way that's actually impacting the treatment and that it's safe. And then sometimes we want to derive great tricks that they've found that are safe and share them with other patients as well. Sometimes these patients can actually mask the side effects and try to tolerate more of the discomfort or pain like we talked about. And this becomes particularly something that I see with peripheral neuropathy in our patients. They don't want to tell you how bad the numbness or the tingling is because their scans keep showing continued improvement in their disease. And as a result, we can sometimes hit a point where we can't manage that side effect anymore without completely stopping the drug. And so sharing with them out front that we can modify things easier and sooner if they tell us when the symptoms first come instead of down the line is important. And then making sure that that patient understands the disease and their goals for treatment. So the next slide that we have here is really how we shift to shared decision-making. And so we want to make sure that it's patient-centered. It helps assure that the treatment plans and factors in their needs, which is what we've discussed here today, and then really better addressing the psychosocial aspects of living with advanced breast cancer. And so over half of patient surveys wish that they had access to more support and resources. So knowing that, we really want to identify what are these resources we can share with our patients. And to do that today, we have Ms. Stauffer, and so I'm going to turn things over to her so she can tell you a little bit about how we engage our patients in that shared decision-making.
Thank you, Erica. I want to talk a little bit about the background for what we're doing and then get into some specific examples. And I have no disclosures or conflicts to report at this time. So we've talked about the importance of shared decision-making and the need for decision support. And we're going to talk about the model that we have developed at Cancer Support Community, which we call Open to Options. And we're going to go through a sample case, which I think will be good. So why decision support? It's amazing how overwhelmed people often feel at the critical points of needing to make a treatment decision. And so often those emotions and fears interfere with the ability to really be objective or prioritize. Oftentimes people don't even know what questions to ask or how to use the information that's been presented to them. And with decision support, we help them clarify their goals and concerns, help them more clearly articulate their questions, and benefit more from the information provided. We'd like to ask if you've ever used or recommended a tool to help patients prioritize their concerns and make treatment decisions. So we'll get back to that in a bit. So there are numerous decision support models available out there, including some really good ones at Dartmouth and the Ottawa Personal Decision Guide. And what we wanted to do was to translate this evidence-based model into our community. And we began to look at different models, and at UCSF, Jeff Belcora has been doing consultation planning and decision support with people with breast cancer for a long time, and so we worked with him to develop a model that works in our setting. And we're really focusing on helping them ask questions, gain confidence in working with their medical team, and being empowered to face cancer. This started out as a pilot with several local affiliates and the national organization, and another couple of entities, including the ENACT organization, which promotes knowledge about clinical trials. It was funded by the Centers for Disease Control. We worked with a really challenging population. We needed to capture them before they had made a decision on treatment for blood cancers. We were able to recruit 73 patients with a diverse type of blood cancers. 17% were minority, and a number of them had comorbidities. Our goals were to enhance access to care, including clinical trials, to reduce decisional regret, to reduce treatment-related anxiety, and to enhance communication with their medical team. In the pilot, folks received educational materials before they came for that consultation planning appointment. They gave their informed consent, completed pre- and post surveys, and went through the scoped intervention, which I'm going to talk about in a minute. And then they completed surveys right after the intervention and at 30 and 90 days, and several measures were used. The scoped model really looks at several key areas: what the key facts and knowledge gaps are for the person in their situation, what they understand their treatment choices are, which may be different from what have been presented to them, what their goals and concerns are as they're considering these treatment options, who helps them when they're going through this process and while they're in treatment, and then looking at how the choices that have been presented to them impact what their goals and objectives are, and then ultimately being able to come to next steps in a possible decision. And what we found was that folks had a significant reduction in anxiety and a feeling of empowerment or self-efficacy after going through the scoped process. They also utilize the tool. We give them a printed copy of their question list and encourage them to give it to the physician when they go in for their appointment. And we found that 93% referred to their question list, and 86% felt that it really contributed to a more productive appointment. The preliminary findings showed that 44 people had made a treatment decision. This may seem a little bit low, but with some blood cancers, oftentimes they have quite a while to make that treatment decision. So it's not surprising that some of them had not come to a decision at the end of the study. But what was really interesting was that 49% reported discussing cancer clinical trials with their oncologist as part of their treatment planning. Some of the feedback you'll see on your screen, folks feeling much less anxious, feeling a sense of getting clearer about how to ask questions, and clarifying their own thoughts, feeling more empowered. We used a particular model, and sometimes in the midst of a clinic setting, it may be difficult to adhere to this model, achieving privacy so that people feel comfortable disclosing their concerns. They often bring their caregiver with them to the appointment. We need to be able to type well enough to get a note going in a short period of time. This says that it was time intensive. It's actually much less intensive now that we're not doing the surveys pre and post. So it's often possible to create a very complete note in less than an hour. It does require some training, and it's important to maintain a neutral, non-directive stance. And this sometimes is very challenging when somebody comes in with a knowledge deficit or they seem not to understand some of the implications that they're bringing up. And it's important that we as facilitators and not medical providers don't give medical advice, and sometimes even that is a little bit challenging. So with our Open to Options program, I'd like to take you through a case. This is a 66-year-old woman who was 3 weeks ago diagnosed with metastatic breast cancer that had already metastasized to her bones. She was stunned because she had no idea that she had advanced breast cancer. It was discovered because she was having some back pain. She has already seen an oncologist and surgeon, and they've recommended chemotherapy and bilateral mastectomy, but because of her high anxiety level, she didn't remember any details about what the doctor said or much about the suggested treatment. She forgot to write it down. She's very uncomfortable about calling back and getting more clarification. But she knows that she didn't understand hormone status, and so she wants to be able to ask that question. She understands that her choices may be a double mastectomy with or without reconstruction, and chemotherapy has been suggested. She thinks she heard hormone therapy. She also has a friend that had been on a clinical trial, so she wants to be sure and ask that question, and whether or not there are other treatments. She thought she had heard about some brand new treatments for breast cancer. She wanted to know about those. And she also wants to know, why does she have to have a mastectomy even if the cancer's already spread to her bones? Because she'd heard about a friend that had advanced cancer, and they said there was no point in doing surgery at the primary location since it had already spread. What's important to her is that she wants to live as long as possible. She wants to be able to stay active. She just retired. She was planning on doing a lot of traveling. She swims every day. She wants to be able to continue swimming. And perhaps just as important is that her granddaughter is getting married next year, and she wants to be able to go to that wedding and not appear sick or have people worry about her. In terms of the people on her team, she has met with that oncologist. She's not completely comfortable yet, and she's very clear that she doesn't want a specific prognosis. She doesn't want numbers. She does want to see an oncologist for a second opinion. She has seen a surgeon, but not a plastic surgeon yet, and she definitely wants the input of her primary care physician. And key otherwise in her life is her husband, who definitely is leaving this decision up to her, but really needs his support in going through this. So the questions that she brought in were pretty minimal. She just had a couple of questions. And through the process of talking about this, we came up with a number of additional questions. So most important to her was, what's going to be done about the bone metastases, and will the pain be alleviated? And how will other metastases be prevented? She's already going toward, if the first treatment doesn't work, then what else is available to her? What treatment would give her the best chance of not having to go through this again? And how will we know if the treatment is working? So she's really at the beginning of her journey, and we might be doing this with somebody else who would be much farther along in their journey and have very different questions that might be more focused on quality of life issues or end of life issues. She wants to know if she needs to come to the oncologist's office for all the treatments and how side effects will be managed. She also wants to know about the surgery questions. If she chooses to have reconstruction, how much more surgery is involved, what's the recovery time, and then some financial issues. What are co-payments going to look like? So she's clearly not at the point where she's ready to make a decision. But what she is clear about, that she needs to meet with the original oncologist again to bring the questions in, to get the questions answered, and to bring along a friend that can take notes so that even if she gets overwhelmed, she'll be able to go back and look at the information. And also she's looking to schedule a second opinion. I think what is important about going through a process like this is that it enhances both the consultation appointment with your regular doctor and also when you're going for a second opinion. The situation that's just a brief synopsis can really help tell the story, as do the objectives, what's important to them. It really increases their self-efficacy. We use their own words in the note. We even include their misconceptions so that the clinician is able to correct some of those misconceptions that they might not even know are present. And we find that this really works best when a patient has scheduled an appointment, is facing a treatment decision within the next few weeks. If it's way out there in the future, it's not going to be as useful to them. And what we also find is that even when there are a lot of emotions involved in trying to come to a decision or even put one's arms around a diagnosis, this neutral approach can help to make it less overwhelming and make them feel clearer, more calm. Sometimes they come in and the questions are all over the map, but they get to see, wow, I'm not crazy. My questions are straightforward. I can ask these at my next appointment. So we have some tools that are available for folks to access for their patients. We do have this service online for people. They can do it over the phone. So they can call the toll-free number, 1-888-793-9355. We have a wonderful resource that is the booklet that comes with, frankly speaking, for advanced breast cancer. And we also have some tools, being prepared, how to make the most of your time with your healthcare team worksheet, a distress screening tool, and the helpline. So we encourage you to avail yourself of those. And now we're going to move into the question and answer portion.
Thank you. We'll now be conducting a question and answer session. You may ask a question through the question box on your screen or through the telephone. If you would like to ask a question through the telephone, please press star 1 on your telephone keypad. A confirmation tone will indicate your line is in the question queue. You may press star 2 if you'd like to remove your question from the queue. For participants using speaker equipment, it may be necessary to pick up your handset before pressing the star keys. Again, if you would like to ask a question via the web, you may use the Ask a Question feature on the left side of your screen. If you'd like to ask a question via the phone, you may do so by pressing star 1 on your telephone keypad. One moment while we poll for questions.
Thank you. This is Ivy Ahmed again. Before we start taking questions, I want to let everybody know, to reiterate what Margaret just said, that the event resources are located on the left-hand side of your screen, and you can download those, particularly the worksheet for patients and the resource list. You can also gather those from our website. And we received a couple of questions online, so I'm going to go ahead and start with those. This first question is for all of our presenters, I think, because it goes across, touches many, many people. How do you, as clinicians, keep spouses and caregivers involved? And then how do you help them with their stress, since many studies report that in long-term care situations, family members' health is lowered?
So I'm happy to answer this question. This is Erica. So I absolutely think that it's important to keep spouses and caregivers involved. We, from the very first time that we meet the patients, encourage them to bring their loved ones and their spouses to the office visits so that we know that the people in their lives that are caring for them at home really know the status of how things are progressing, know what the plan is, and know the bigger picture issues. And for the most part, I find with this population, they do bring a mom or a sister or a husband or another spouse with them to the visits. And especially when things are ending, coming nearer to end of life, we often will encourage them, if they haven't been bringing someone, to really begin to. And oftentimes I will step aside, whether it's in the waiting room or while the patient's changing before they're leaving, and ask the caregiver how they're holding up and let them know that we're always available to them if they need to talk or to plug them into other resources, because it is difficult caring for someone that has a chronic illness. And so I absolutely think you are caring for the whole family in many ways and not just that patient. So not being afraid to, offer your support to them as well.
Great. Thank you so much, Erica. The next question is specifically for Dr. Shapira. About how often do you find yourself helping patients get organized and prioritize when they're in an appointment?
That's a great question. Can you hear me? Yes? It's a great question. Often, I can't give you a percentage, but I am often in situations where patients are anxious and vulnerable and disorganized, and I take that also as a symptom that they're not coping very well. So I think that I try to figure out who they're talking to, as was said previously, who's supporting them, but I sort of model for them what I want them to do with their own relatives, loved ones, and perhaps also with another member of my team. So I really very directly ask, what's most important if we have to choose between A and B, help me understand what's most important to you. And I think that sometimes it doesn't immediately come over very well the first time, but as with many other of these psycho-ed approaches, if you do it enough times, I think you and your patient sort of learn how to do this dance together and figure out how you're going to make a decision together based on their preferences and goals.
Great. Thank you so much. We also have another question, and it is, many of my patients tell me that their doctors are not always engaging in discussion around treatment options and outcomes. So how, as clinicians, do we encourage them to ask doctors who are not engaging? How do you help patients to be more vocal and engaged?
Yeah, well, I don't recommend strangling the doctors or being hostile, even though you may want to. So I think, again, with patients, you can ask them exactly what they've said. When you ask the doctor specifically this, what does the doctor say? And you can try to figure out, what's going on there. Remember that you don't really know what's actually happening in that consultation room. You only know what your patient perhaps is telling you happened. So I think that, as with any other complicated communication, you need to try to figure out through good questions where you think and make a diagnosis of where you think the communication breaks down, give your patients some ideas, coach them, ask them to try a different approach, ask them to bring somebody else, give them some examples, and then debrief with them.
Great. Thank you very much. And we do have another question, and it's actually for all three of the clinicians, and I think it's how do you work with navigators in your setting? There are different types of navigators. How do you work with them, and do you leverage any of them to deliver psychosocial support? Maybe we start with Margaret.
Okay, I'm happy to talk to that. There are a number of patient navigators at the different health centers in our area, and not only do they refer to us to assist with psychosocial support, but we can also get the patient hooked up back with them if there's been a problem. that they may not be aware of. So to make a direct call on the patient's behalf and get the communication going again. We know that people do better when they're supported through the process of navigating the health system. So we work with them as much as we can.
Thanks. And Erica, did you have any particular thoughts on that question?
Sure. I really agree with a lot of those points. I have seen institutions that have worked with navigators. I've also seen institutions where the office practice nurse adopts the role of the navigator. But I absolutely think in most cases where people are fulfilling that role as a navigator, they have had training and absolutely can add to the psychosocial care. You don't need to be a nurse or a doctor or a social worker to provide that type of care to a patient. You just need to be a compassionate person and lend yourself to assisting them find the resources that they need.
Great. And Dr. Shapiro, did you have anything that you wanted to add to that?
I agree with my colleagues here. I think that the roles of navigators are defined differently in different institutions, and often it's the person who is in that role who really can provide a variety of different services, but it depends very much on what he or she feels comfortable doing. Sometimes navigators are really are cultural brokers. They in certain situations I've seen navigators who are members of a culture, and they're able to really help bridge that interface with families who would otherwise be absolutely lost. So it depends a lot on the individual, the community, the setting, and I think my advice would be to know the navigators that you are working with and see what they're willing to do, and the best thing to do is to just ask them.
Great. That's wonderful insight from all three of you. And actually, to dovetail with that question, we received a question about how do you see chaplains as part of the interdisciplinary team?
Well, I'll take a stab at that since one of my best friends is a chaplain, and I have this conversation often. I think it depends, again, on who you have to work with. I know many great oncologists who don't have chaplains, who work in offices and private practices and so on, and they just don't have that, so they need to explore with a patient where they can find that kind of spiritual, existential, or specifically religious help. If you are fortunate enough to have chaplains where you work, you should know who they are. You should have a personal relationship, and I think refer often. And just, again, it's one of those things where if you think about it all the time and you routinize it, you just ask the patients if they want to speak to a chaplain, if that would help them think through their worries and perhaps even get some more clarity about what their preferences and goals are based on beliefs or background. So I think offering to refer to colleagues who are chaplains is great, but I'm very mindful of the fact that not everybody works with chaplains or has access to chaplains.
Great. Thank you very much. Margaret or Erica, did you want to add anything to that?
No, I think that was a great answer. I agree.
Great. So I think this is actually going to be our last question, and it's how do we better differentiate palliative and end-of-life care for these patients?
Oh. Do you want me to take that?
Great.
I'm happy to do that. So it's a fine distinction. For some people, it's an important distinction to make, and for others, it isn't. I think palliative care is sort of almost a philosophy of care, and it's aimed at making patients live as well as they can, and it also extends to giving care not just to the patient, but their network of supporters, typically family, relatives, and family caregivers. So, palliative care becomes more and more important as the burden of symptoms increases, and those symptoms can be physical and or emotional, and it extends to the end of life. For some people, accepting any form of palliation that is phrased as palliation is somehow culturally impossible, so that the only time that we can actually get them to accept this is when we're focusing at the very end of life, the last few days or weeks of life. In my mind, if we can all work together to diminish those barriers to referring to palliative care, we will be doing our patients a great service.
Great. Thank you very much. And with that, I'd like to thank our presenters. You did an excellent job. It's a very meaningful and insightful presentation. Your enthusiasm has been great, and the questions from the audience were wonderful. Please remember to visit our website, cancersupportcommunity.org, or call CSC's toll-free line at 888-793-9355 if you'd like additional information. And we'd also like to thank our sponsor for today's webinar, Celgene Corporation. I apologize for the city noises. So for those of you online, if you could just take a moment to complete our post-event online survey, which you'll be redirected to shortly. It's brief, and we certainly appreciate any feedback that you might have.
This concludes today's teleconference. You may disconnect your lines at this time. Thank you for your participation.